Welcome, everyone. Welcome to the Rashes in Children webinar for clinicians working in PPCCs and UCCs, but also others with an interest in urgent care in Victoria. Before we get into it today, I would like to just acknowledge that Northwest Melbourne Primary Health Network would like to acknowledge the traditional custodians of the land on which our work takes place. Now, for us, that's the Wurundjeri Woiwurrung people, the Bunurong people, and the Wathaurong people. We pay respects to elders past, present, and emerging, as well as pay respects to any Aboriginal and Torres Strait Islander people in the session with us today. Okay, a little bit of housekeeping. You guys probably know all of this already. You're all muted. And we're going to ask you, please, to keep your questions that you want to ask to the Q&A box. And then at the end of the slide, I will stop Sandy and we will go through your questions, and you can all have a giggle at my pronunciation of various technical aspects. But if I need to, we will, usually the presenters are very good and understand what I'm saying. Sandy may also ask you to have a guess at what we're looking at. And if you could put that in the chat, that'd be brilliant, because Sandy will then monitor the chat. Now, this session is being recorded and you will receive a link to this recording and a copy of the slides in a post-session correspondence. And we're going to do questions anonymously to protect your privacy. So that red circle shows you what the chat looks like, and that's where you're going to put in all your responses to Sandy's questions, but your questions will go into the Q&A, which is the non-circled thing next to it. Now, please ensure you have joined the session using the same name as your event registration or phone number if you've dialed in, and that's so that you can get that the CPD points. So we'll use the Zoom participation list to mark attendance, and certificates and CPD will not be issued if we can't confirm your attendance. So unfortunately, at the previous webinar, we had some people that maybe said their clinic's name, but not their name. So we weren't able to give them their CPD points. If you're not sure your name matches, please send a chat message to Northwest Melbourne PHN Education to identify yourself. Now, I want to just touch on Health Pathways before we start. Health Pathways Melbourne is an online resource. Now, the one that we're going to look at tonight has been developed by Eastern and Northwestern Melbourne Primary Health Network, but every region in Victoria has a very similar setup. So we're going to be looking at how to get in on the East and Northwest health pathways, but everybody else does have a similar setup. Health Pathways Melbourne is an online resource and has been developed in collaboration with local healthcare professionals. I'll be showing you how to navigate it, but other PHNs throughout the state have their own version with a similar setup. My colleague Elisa will post the other Health Pathways link in Basecamp in the next few days. Or last time it was also in the email that comes out with the recording. To access Health Pathways Melbourne, go to the website address melbourne.healthpathways.org.au and we will send you the other addresses. Health Pathways Melbourne is available to clinicians, and the information that you'll get from Melbourne Health Pathways is localised. So if you're thinking, look, I work in Gippsland, but I'll want to sign into this one, it's not going to be very useful to you because the information is localised. So the process of developing content for Health Pathways is a collaborative effort between local GPs, specialist allied health providers, and other subject matter experts. Each pathway is evidence-informed, but also reflects local reality. Health Pathways Melbourne provides clinicians with a single website to access a comprehensive collection of locally relevant clinical information. The aim is to enhance clinical knowledge and promote best practice. It improves the quality of pre-referral workup and reduces delays with referrals. And it provides you with local information, and that could be very useful too if you are a locum working in an urgent care clinic. So this presentation will just now have a quick look at how Health Pathways Melbourne finds relevant information pathways on management for rashes in children, with particular reference to clinical staff working in PPCCs and UCCs, but also anyone interested in this topic. So if we just have a quick look, this is the landing page. This is what you're faced with when you get into it. It's very, very simple and easy. It's really user-friendly. So down the left, the search bar is towards the top of the screen. You can see there we've got rash unwell children, and the pathway links are on the left-hand side. Each pathway has an optional send feedback button in order to ensure the information is up to date and useful. So it's a very dynamic database. It's not out of date. The advantage of using a database like this is it helps provide local knowledge, and it also contains GP-only direct hospital contact numbers, which is very, very useful. It also improves the quality of pre-referral workup and reduces delays with referrals. What you can see now is a range of referral pathways and information to do with rashes in children. So that's the sort of information that you would get from a search on rashes in children. That's it for our information on health pathways. I am now going to hand over to Dr. Sandy Hopper. Now, Sandy is a dual qualified emergency physician and emergency paediatrician working at the emergency department of the Royal Children's Hospital in Melbourne. Having just clocked over 20 years of consultant work at RCH, he has just stepped down as Director of Paediatric Emergency Training. I did not realise that, Sandy, but remains passionate about bringing up the next generation of talent in the field, which includes you. His research interests include mental health, procedural care, orthopaedics, hospital in the home, observational medicine, and consumer information. I am now going to hand over the reins to you, Sandy.
Terrific. Thanks very much, Della. As I said, my name's Sandy Hopper. Please call me Sandy if you're going to chat with me. I'm running sort of dual screens here. I'll have a webinar chat on the side, and if you see me squinting, it's because I'm running it on my smaller screen. So let me just share my screen with the presentation. Just confirming that's up and running, Della?
Yeah,
great.
You're right.
Okay, so we've got about 80 minutes or so of paediatric rashes. So I wonder if we go for 40 minutes, have a 3-minute break, stretch our legs, freshen up our brain, and then have a sprint session to the end. I think that might be a good way to go so that we don't get numb in our various posterior regions. The goals of this talk, rather than a four on the floor talk regarding all the different common rashes, I thought I'd focus on causes of anxiety for all of us, including parents, GPs, and referrers. And probably the touch points here are rashes in neonates, serious diseases with rashes that need ED care, and less serious rashes that can be managed in the community. But I think rashes that we see, parents self-referring and GPs referring, and parents self-referring after GP care. So probably a number of rashes that are less common and a little bit harder to manage, so that we can focus our care on emergency patients. And I've roughly triaged them into 3 categories. One is please send to emergency. The other is manage yourself, keep calm and stay home. And the other one is something that needs referral to a dermatologist. And I'm not sure about dermatologists in your regions, but if you want someone to be seen this year, you really do need to pick up the phone rather than write a referral letter. So with no further ado, we'll talk about the key principles. And this really, I think this really transcends all of paediatric medicine. It's the clinical condition and the appearance of the child, trumps pretty much everything else that is going on. A sick child is a sick child, regardless of whether or not they have a rash, regardless of whether the rash looks benign or horrible. And conversely, a well child with a horrible looking rash is probably a well child. And that's the same when it comes to fever, when it comes to vomiting, when it comes to abdominal pain. So your global assessment of the child's clinical condition takes precedence over almost any sort of morphological or historical feature we're talking about here. Okay, let's dive in. Let's go for some. Let's get the blues. Okay, these are some purple or blue rashes. My baby has purple feet. This is a 7-day-old baby who's presented with purple hands and purple feet. The baby is otherwise well, a term baby, in fact, a post-term baby with good APGARs, 4.2 kilos, bright and interactive or bright and active, but has these startlingly purple feet. What do we think's going on? And I'm happy if you want to throw that up into the chat. I'll give it about 15 seconds while I have a slurp of tea.
So if people want to put their guesses in the chat, that would be brilliant. Thank you.
Yep, great. We're getting hypothyroidism or hypothermia. Yeah, good thought there. Yes, so this is a well baby who has a normal temperature, is nice and bright and alert. But certainly you'd consider those two diagnoses in this sort of child. Certainly if they were tachycardic and drowsy and vomiting, you'd say that's a sick baby with circulatory problems. Sepsis, agreed, if they're an unwell child. In this case, this is a well-looking child who has a normal set of obs, is neither hypothermic nor febrile. Normal. Yeah, okay, I'd pick normal. So this is called acrocyanosis or purple hands and feet. It's caused by vasospasm of the small vessels of skin in response to cold. It's peripheral and there's no central cyanosis, although lips can be a little bit blue, a little bit of a blue moustache. It resolves with warming of the peripheries. It's unusual after the first month. But of course, you'd want to make sure that your child is well. If your child is well, solely with purple hands and feet, you call that acrocyanosis. And you keep calm and the child stays home. Any questions there? And you can put them in Q&A if you like, or you can put them in the webinar chat.
So no questions at this point, Sandy, but a few people did think we had a normal baby there, which is great.
Yeah, that's good. Yeah, I would agree that acrocyanosis in a well child is acrocyanosis, a normal variant. In a sick child, it could represent circulatory catastrophe and sepsis. Agreed. Okay, we're going to move on to the next one. This is a child referred to you by a maternal and child health nurse with bruising. Bruising FI, could this be a child at risk? What do we think? Story is 3-weeker, born at term, hasn't seen the maternal and child health nurse before, second child. And we're getting, most people calling it Mongolian birthmark, Mongolian blue spot, a few people talking about bruising, and really that's the crux of this. This is referred in with bruising, but you really want to figure out if this actually is bruising or if this is congenital dermal melanosis or Mongolian blue spot, which I think is a slightly ethnically charged term, so we're tending to use congenital dermal melanosis these days. How do you tell the difference? And I'm sure you get these referred by maternal child health nurse, maybe even kindergartens. We certainly get them ourselves, and we get them referred by child protection. Okay, I'm going to cut to the answer. On the left is congenital dermal melanosis, and on the right, the column is bruising. So if you have flat, uniform, bluish-grey lesions, poorly circumscribed, they do not change over the time, they're not tender, and especially if it's in the lumbosacral region, you're heavily in favour of a congenital dermal melanosis. On the other hand, if you see purple marks with a variable hue, maybe a bit of brown, maybe a bit of yellow, if they're a little bit swollen, if they're tender, if they're evolving over time, if they're in areas other than the typical areas, which are usually the lumbosacral region, occasionally the hand, then you would be concerned about bruising. Do we have questions on that?
No questions at the moment, Sandy.
No questions. So a couple of practice tips there. It is useful, especially because these are usually atypical congenital dermal melanoses that are referred in, because most people know what a typical blue spot is. If you have that, it's good to give the parents a copy of your notes or a letter and ask them to take a photo, because someone in the future is going to say that's a bruise and call child protection, and the parent can produce the documentation that has been previously diagnosed. And I've got a number of friends whose kids have that, and that's what they do. And if you take a photo from, when the baby's born and they're 18 months old and it's still there, it's clearly not going to be a bruise. Okay, this is a well baby with a small blue-brown spot on the chest. Hopefully your screen resolution is good there. What do we think that is? We've got a bruise come up as a possibility here. Other people? Mastocytoma, yep. Blueberry muffin baby, could be. It's sort of browny and it's faded on the edges. It's a little bit indurated. So this for me is a bruise, and I've got on the next slide, I've got a number of images of bruises. And for me, this is a bruise because it's brown, it's a little bit indurated, and it doesn't have the appearance of any other sort of lesion. And the significance for this particular spot is that if you're seeing little brown spots, especially just on the cheek of small babies, on the earlobe, on the arm, in the young age group, in the under 6-month age group, a presentation with a bruise has a mortality of 30 to 50% later on in life, because this is an extreme case of child at risk. So this should be taken very seriously. If you're seeing bruises on a small baby who can't move around, they need to be referred in. Questions there?
Sandy, is there a difference between this sort of bruising and the bruising that you were showing on a previous slide, which was more likely to be dermal melanosis? Is there a difference?
Yeah, I'm just going to toggle backwards and forwards. So just if people can see this, we've got on the helix of the ear, you've got purple with variable hue. On the arm, you've got a row of fingerprint bruises, I would say. We've got yellow and red in the middle, and you've got some geometric patterns on the cheek, and they're all red or brown or purple. The one on the chest in the small baby is brown with fading, and then the congenital dermal melanosis is very much black-blue and uniform in colour and quite patchy, and it'd be hard to think of a mechanism that could cause a bruise in that sort of almost sort of cloudscape geometrical pattern. So yeah, very, very uniform and very blue for me is the giveaway. The bruises are very much a brownie or a variable colour, yellow, red, purple in there with some yellow on the side. It can be hard, and I think if you've got any doubt, we're really happy to see kids where you've got some question, because the stakes are high, and we're really happy to see them, and we often take photos and we call the forensic service and say, we're not sure, what do you think? And we sort these out because the stakes are extremely high in this sort of case.
Sandy, how would you deal with the parent with you? Would you just report rather than confront?
Yeah, if you've got a child with unexplained bruising, for me the standard line is that there's bruising on the child for which there's no explanation or mechanism. We need to take that seriously. And then you, in a roundabout way, you talk about the fact that this raises the possibility of someone inflicting an injury on the child, which is very confronting for families. You need to be quite soft and sensitive, but by the same token, this is such a serious problem. And you are the advocate for the child, and possibly the only advocate for the child in the room. So you need to be fairly brave, but sensitive at the same time. I think I would suggest in a general practice context, if you see a baby of this age with these sorts of bruises, you would be referring in because the child, there's a fair possibility the child is not safe at home, so can't go back home. So you can't manage this in your clinic. And you would probably refer to DHHS at the same time. And we're very happy, or the closest paediatric service would be very happy to see these patients. Happy might not be the right word, prepared, and we view it as our responsibility. Okay. We're running through more purple spots. So this is a child who's well in every respect, but has what are clearly bruises and some fine pinpoint bruises. And the child on the right has more extensive bruises. They're flat and they're non-tender. What do we think? And they're purple and they're non-blanching. This child is well in themselves. So we're getting ITP, immune or idiopathic thrombocytopenia, thrombocytopenic purpura, mouthful, better to call it ITP for sure. Other thoughts? Purpura, yep. And it's clear that you've got purpura and petechiae on this child. So that's a hallmark of thrombocytopenia. So let's think about the causes of thrombocytopenia. Well, let's think about the causes of petechiae and purpura. Trauma being one of them, of course, but non-tender, easy bruising throughout the skin. HSP, it's coming up. Idiopathic, excellent. Hematological malignancy, yes. Viral illness with capillary fragility, agreed. Yep. DIC, yep, in the right context. DIC, obviously septic, in really bad shape. But yes, we do see that. This is my list. This is my list. We do see a range of children who have localized trauma or pressure areas. One we see is bilateral petechiae of the lower limbs in a young baby. We call it baby Bjorn legs. So it's been a tourniquet effect from the baby Bjorn being the commonest baby carrier. We also see coughing, vomiting and giving birth, although not really in the paediatric age group, with SVC from the nipple line up, with no other sign of bleeding or bruising. And we see kids who have been roughhousing grabbed by the collar. You see sort of ring of collar petechiae as an example. So if you've got trauma or pressure and there's no other sign of bleeding or bruising, then you could possibly not do a full blood count in a film. All other patients, I think, need a full blood count in a film for the reason that both hematological malignancy and immune thrombocytopenic purpura are probably the two more common causes. The clinical context can give you an idea what's going on. Obviously, you've got a well child with a recent viral illness with no pallor, no enlarged spleen, looks well in themselves, no bone pain. It's probably ITP. If they're very unwell, then yes, sepsis with DIC for sure. If they've got nodes, pallor, fever, enlarged liver, enlarged spleen, then you're thinking acute lymphoblastic leukemia. And as I said before, if it's localized to, say, just the lower limbs in the right context, then we would talk about hormone pressure. And yes, children with viral illnesses do have capillary fragility. So enteroviral being one of them, have like lots of red spots and a few petechiae. We see that all the time. But otherwise, well, we don't tend to worry too much. So depending on how the child looks and what you think the cause is, and what your local services are in terms of getting a turnaround on a blood count, you may well refer in or you may keep it up. Questions from there?
No questions at the moment, Sandy.
No questions, great. I'll take that as being that I'm covering everything magnificently. All right, this is a child with a recent viral illness, has a purple rash. These are not tender, they are non-blanching, and you can feel them. They're palpable. So palpable purpura in a well child who's a bit sore, maybe a swollen ankle. And yeah, this is a fairly typical rash for HSP, Hinox-Schönlein purpura. Agreed. Agreed. It's really very much a visual diagnosis. So how do we work up HSP, suspected HSP? What do we do here? And I'd say that if you've, depending on, you could probably do your initial workup in your surgery for this particular disease if the child is well. What's our minimum investigation? And it's okay if you don't know, that's fine. There's a great RCH clinical practice guideline on this. Yep. I think you're all on the right track. So look, what I do here is I do a urinalysis and a blood pressure. If the urine is benign and they're normotensive, I don't tend to do blood work on these children, but if there's anything on the suggesting renal disease, which is the commonest major complication, then I would be doing UEC, and possibly you're referring that patient in who's got, say, an active sediment in urine or a little bit hypertensive, you'd probably be referring them in. If that's normal, then close follow-up, because renal disease can intervene at any time. Good parent information sheet on RCH webpage. Then the role of steroids. Do we use steroids? Do you want to use steroids? What do you think? And yeah, steroids and HSP really keep paediatricians entertained for hours and hours on end. The debates are magnificent. But for me, in general, I use steroids for complications. Renal complications, abdominal complications, possibly severe joints and other more unusual complications. But I usually talk to my paediatric colleagues, because these are kids who are sore. So steroids for pain complications and renal referral if blood pressure or urine changes. And keep a close eye. There's been a few kids who have been lost to follow-up and come back with bad kidneys. So it's, for me, I really stress to the parents that it's important that they stay in touch in terms of blood pressure and urinalysis. Fever, unwell and rash. Another purple rash. We're still on the blues here. This is an unwell child, non-blanching rash and meningococcal. I think this is one that keeps us awake at night. None of us like seeing this condition. None of us like trying to manage the risk of this condition. But yes, this is meningococcal disease. Before the purpura develop, they're usually very unwell. So in children who are very unwell, I do a top-to-toe exam. Even 1 or 2 purpura, I'm really jumping on that. Even if they're very unwell with no rash, I'm jumping on it. Even with very unwell with a few red spots, some joint pain, I'm jumping on it. We are seeing a lot of more group A strep sepsis than meningococcal these days. But many of us have been not burnt by these cases, but possibly even traumatised because they're very sick children. So if you
Sandy,
yeah,
sorry, I've
ahead.
just got a question. And before we go to that, what time frame and frequency would you follow a child with HSP4 in the community? Just briefly, because most urgent care clinics wouldn't be doing follow-up, but just briefly, could you comment on what time frame and what frequency would you follow a child with HSP4 in the community?
Yeah, it's on the CPG. My recollection is it's weekly for a month, and then monthly for a year, and then yearly for the rest of your life. In terms of, good question. What I often do is I send, in my referral letter, I send a link to the CPG or even a paper copy of the CPG, acknowledging that this is an uncommon condition and the GPs might need support for that. But it's on the guideline.
Brilliant, thank you.
So yeah, with the PPCC, you'd be referring back to their usual GP or ask him to source a local GP. Would that be the way?
Yes, that's absolutely right.
Yeah.
Yep.
Understood. Okay. So if we're suspecting meningococcal, what do you do? It's actually a question I've got for you as GPs. I know when I had a doctor's bag, it used to have penicillin in it, but not ceftriaxone. Do you have the ceftriaxone in your doctor's bag these days? Single dose of intramuscular ceftriaxone.
If you could just answer that in the chat, that would be brilliant.
You can answer in the chat. IM antibiotics and call ambulance. Yes. And I think, James, you're probably saying, yes, you got ceftriaxone. Yeah, that's good. I think I agree. IM antibiotics, I mean, you might have facility to thread in a line and give IV antibiotics and some IV fluids. That would be great. If you don't, that's okay. Give IM antibiotics and ship them off as soon as possible. This is a disease that can go from looking not too bad to looking horrible in half an hour. So, ceftriaxone not on PBS or doctor's bag. Okay. So ambulance carries it. So that's, at least Victorian ambulances do. So that's one way you can get access to it. But yeah, if you suspect it, it's a no questions asked, refer them in, and we would know that there is over referral of query meningococcal disease, just as there's over referral of febrile illness could be sick. That is the landscape. I think, as Claire Wilkin mentioned in previous talk, we have a lot of children who we watch for 3, 4, 5, 6 hours because they look sick, but we think they're viral. We're waiting for them to improve. We're intervening if they don't. We're doing that actually hundreds of times a month, and we're seeing one case of sepsis, and they're the odds that we're playing in our environment. In the general practice environment, you've probably got a much broader spectrum. So by necessity, you would be referring in children where we think they're okay, and we turn them around, and that's the odds game that we're all playing, and that's absolutely fine.
Sandy, I've got a couple of
Yep.
questions here.
Yeah, go ahead.
Just when we're talking about what to give these presentations, we've got a question: how much and what?
Yeah, so 50 milligram per kilogram up to 2 grams would be what I'd recommend, intramuscular of ceftriaxone. If you've only got penicillin, then 60 milligram per kilogram IM. If that's all you've got and there's delay in obtaining ceftriaxone with an ambulance, that would be better than nothing and probably okay. The question of the place for steroids. So we need to pull apart, I think, meningitis from meningococcal disease. So there is overlap with the rash, but meningitis is infection of the lining of the brain involving severe headache, vomiting, altered mental state. And meningococcal is a disease of circulation, circulatory changes, muscle aches with microinfarcts, etc. So steroids are indicated early before antibiotics if you suspect meningitis. Unfortunately, it's really unclear in most cases that you're sitting on meningitis. They're non-specific because they're younger children. So in reality, we often don't give steroids because we're doing the lumbar puncture first, etc. In terms of meningococcal, where you think their mental state is okay and they don't have meningitis, there's no need to give steroids. There's no benefit there. Possibly down the track, if you're battling circulatory failure and overwhelming sepsis, steroids might have a role, but I don't think that's a PPCC situation. At least I hope you never have to try and manage that in PPCC. Other questions, Della, from the Q&A?
No, thanks.
Great. Okay, early antibiotics, which we talked about that, close monitoring and expedite to ED care. If you can get a line in and give some fluids, I think that's really good. By the same token, don't let that delay administration of antibiotics and transport to high acuity environment. Okay, we're getting away from the blues. We're going to the reds now. So lots of red lumps. This is a little red patch which is developing at 3 weeks of age in a previously well baby. It's gone from a little soft, flat red patch to now something a little bit fleshier. It's near the ear. What do we think it is? Yeah, a few things coming through with hemangioma. Yeah, it is. It's red. It's chronic. So it's there for a long time. It's growing. It's a hemangioma. It's a little cluster of red cells. So what's the significance of a strawberry? This is growing into a fleshy wound, fleshy lump. So it's going to be a strawberry hemangioma. What happens to them? They bleed. They certainly do. They get bigger and regress with age. All three of you are right. So what happens is they start off flat. They turn into something that looks like a strawberry. And then they go away. And that's a nice clinical progression that you see for a strawberry hemangioma. Issues, they grow, and if they're in vulnerable areas, often the nappy region is probably the hardest to manage, something in the natal cleft or in the groin. It's vulnerable to moisture and other material in the nappy region. They ulcerate a lot. They're very hard to manage. The other ones that are near an opening, so pretty much any opening you want to mention, if you've got a fleshy lump growing there, it's going to cause problems around vision, around eating, breathing, weeing, pooing. you name it. So they're the ones that should be referred. And you don't need to refer into ED. You can call a dermatologist for them. We have our own hemangioma clinic at RCH, and I think if you're rurally based, a lot of the rural paediatricians be quite happy to manage this with propranolol of all things, which makes them involute and go away. Questions on strawberry nevi?
No, none.
No. Okay. So I think the practice tip here is if you're seeing something like that at a young age, you might be referring in, or you might just say, I'll see you in a week, or if it's getting bigger, give me a call. Because if you get onto it early with the propranolol, then, and it starts to regress earlier in the course of its growth, you have less chance of ulceration. It'll be a lot easier to manage. So if you're seeing something like that starting in a baby on a, say, 6-week baby chat, how much propranolol? To be honest, I don't know. We have a guideline. The propranolol used to be started in hospital because we were worried about hypoglycemia and hypotension, but they're much more relaxed about that. They usually start as an outpatient. And to be honest, I don't start it because I work in emergency. I pick up the phone and call my dermatologist to help me out.
Sandy, we've got a question here about, as you know, PPCCs and UCCs see urgent presentations. Catherine's asking, are there any concerns if the little red patch is near the ear as it is in the picture?
Yes, in the medium term, because if that occludes the ear canal, then you could have hearing loss at a really vital developmental stage. Likewise, if it's near the eye, you can have a obscuration of vision at a vision development stage, and obviously around feeding and elimination as well. So yeah, there is a concern, but it's not something that's going to happen in a week. It's going to happen over a few months. Question of propranolol, is it topical? No, it's oral. It's oral propranolol, systemic. Okay. Itchy red lumps come and go. We see this rash all the time. So this is a child preceding viral infection, but let's face it, this is Melbourne. Everyone's had a preceding viral infection. This rash comes and goes with large red welts. Child is itchy. And yeah, this is urticaria. This is probably one of the commonest rashes we see. And my sort of opening spray to the parents is this is a terrible looking rash, one of the biggest rashes we see, but one of the least impactful rashes, and completely benign. We see them coming in because they're not getting better. We see them coming in because they're still symptomatic. And for me, the management of, well, actually, let's throw it open. How do you treat urticaria? Steroids, antihistamines, corticosteroids and antihistamines. Now, I've lost my screen. Have you all lost my screen as well?
Yes, we have, Sandy.
Problem?
It's gone black. I can see your cursor, but we can't see the presentation.
That's interesting.
Yep, you're back.
You can see it now?
But
okay,
we see not yet.
You see slide view?
Yep.
Okay,
it's back.
I don't know, that was a gremlin, wasn't it? Okay, we're getting antihistamines, school packs, removal of trigger, agreed. Steroids, if chronic, refer to allergist. Agreed. Reduce irritants. Yeah. So my treatment here is the mainstay is cooling and antihistamines, which can be given in double dose, so twice a day. The cooling treatment, I actually say if it's quite prominent, I say wear wet pajamas. because the evaporative cooling just cools the skin down completely. I tend not to use corticosteroids. I don't think they work at all, either systemic or topical. In terms of my advice, I'm very much an underpromise, over-deliver kind of a person. I say that this will keep coming and going for weeks, if not a month, knowing that it'll probably come and go for about a week. Because people keep coming back saying, it's still there. It's like, yes, it's still there. I validate their experience, and it is very itchy, and some children are really jumping out of their skin. Cooling treatment with cool bedclothes, avoidance of prickle, I think all that's in there. Just
Sandy,
checking off-label cetirizine as a dose. I was told can have double the dose. Yes, it's off-label, but yes, you can use it twice a day. Yep. I probably, if it was a 6 to 12 month, I wouldn't do it. But in those older kids, that's what our dermatologists tell us first line. Yep.
Sandy, I've got a question from the Q&A. Is it always caused by an allergy reaction, or can it be from a virus?
Yeah, good question. Because we get, can I see an allergist, please? And it's about a 40-40-20 split on 40% recent viral infection, 40% recent medicine. Sometimes about 2 weeks ago, so you need to, medical history could be distant. And of course, you've got plenty of kids who've had fever, cough, runny nose, amoxicillin, and then a week later get a rash, and you never know which one it is. So, but the stats are 40-40, and then the rest are sort of random things. There's a small handful related to exposures to washing powder and so on. The parents, in my experience, are usually chasing some specific allergen, have changed the washing powder, have done a whole lot of stuff, whereas it's probably a viral driver, which can even be subclinical. If it's in particular localized areas, you can get contact urticaria, and you're talking jewelry, so necklaces, ears, belt buckle, watches, and sometimes if the child has a facial urticaria after hugging Nana's been wearing metal jewelry. There's a few of the sort of very localized patterns that might have a contact history, but most of the time you might as well say it's a subclinical virus. Preferred over-the-counter antihistamines, this is the cheapest one. Really. Topical steroids, no, I don't tend to use them. I don't think they work. I tend to sort of de-escalate that care and just use antihistamines and reassurance. And agreed, refer if chronic, so that's 2 months. And write a clearance certificate for school or creche. This is not infectious. They can go to school or creche. Questions on that?
No questions, but Sandy, I don't know if your slide presentation has moved up. So it's, for me, it's still on treatment advice referral. Is that correct? Ah, there we go.
There it is. Sorry, forgot to click. So it can be managed in the community. I think with a under promise over deliver kind of set of advice, saying that it's going to keep going for quite some time. It's going to be random. It's going to be in different places, and we see a lot of parents. And I'm not casting aspersions on this audience, and clearly we don't see every patient managed by a GP. We see a lot of parents who have been managed by GPs who said it's still there, and they haven't at least heard that information from the GP.
Sandy, we've got a question. What would the approach or treatment be if the child was, is that greater than 6 months old, Suleiman?
Probably less than 6 months old. That's the controversy there.
Less than 6 months old, sorry.
Yeah, it's pretty unusual to get urticaria under that age group, but I would be shy of antihistamines. You might give some steroids because it's something you can do, some local cooling measures. I would probably I think food exposure history on that child would be important. That if it's in that younger age group, we probably see food allergies a bit more, and that tends to be facial urticaria. So no antihistamines. I think if you read the packet, it says not under 2 years, which is pretty unhelpful. But then again, about 90% of all drugs we use in young children are off-label. Okay, moving along. This is a 15-day-old baby with a rash that comes and goes. And we're going to have a break after this one. I think we're making pretty good progress. But it'd be good for us just to get the circulation going again. So this is a 15-day-old baby with a rash that comes and goes. Quite prominent, quite red. What do we think? We're getting infantile acne come through. Neonatal acne. Milia, ET, erythema toxicum. Yep. In fact, this is erythema toxicum. So little red spots with little pussy centers, quite red, a well child. Not really kind of big and lumpy, but I think there's really a kind of, for me at least, there's a kind of spectrum around neonatal acne and erythema toxicum. But if these little ones without too much of the deep stuff, then it's probably erythema toxicum. So it's benign, it comes and goes. What is the treatment? And the medical students don't know who that character is up on the top, right? And it's a dead flat joke with the kids these days, but I suppose it shows them the need. Nothing. Agreed. Treatment is Photoshop the baby photos. So I agree with you all. It is self-limiting. It will come and go. And you can use some just normal standard baby treatment and reassurance. Okay, so I've got 6:50. We've got 35 minutes to go. Della, would it be okay if we had let's have a 3-minute break?
It is. And while everyone's having that break, perhaps I could just ask you a question and then I'll type the answer. The question is, urticaria with other symptoms over 4 weeks? Question mark. Further investigation?
Yeah, it depends on those other symptoms. I suppose if you've got urticaria that comes and goes in relation to a food, then you're thinking food allergy. If you've got urticaria, cough, wheeze, floppiness, then you may be thinking anaphylaxis. Depends on the other symptoms, I suppose. And then there's some really rare stuff around some of the malignancies that cause an urticaria type reaction. But those babies have lots of other things going on. I think if you're dealing with a small baby with urticaria that you think is weird, and I use that term loosely, refer in because it's unusual. I agree. It's out of the range of your standard urticaria. Could be something else going on. Maybe it needs some testing. Maybe it doesn't. And I must say, I'd be looking at that child and doing a good history and reaching out to my immunology and dermatology colleagues with that. So yeah, I'd refer you. Yeah.
Brilliant. Okay, then thank you. Now, if everyone wants to have a quick break, when will you be back, Sandy?
I got 6:58. So 6:55 now. So how about I'm back at 6:58?
Brilliant.
Quick
Alrighty.
3-minute stretch the leg stop, so to speak.
Excellent. Thanks, Sandy.
All right.
Hello, you are currently watching the Rashes in Children webinar with Dr. Sandy Hopper from the Royal Children's Hospital. We are just coming back from a very short break, and once Sandy has got his screen sharing happening again, we are going to resume.
Okay, Della, just checking, can you still see the screen or do I need to fire that
Yes.
up again?
Yeah.
Great. Okay.
We've got the screen happening and we've got questions. We've got people with their hands up, but we're just going to ask you to put your questions into the Q&A. I'm absolutely monitoring that and we'll get your questions answered. So we actually have a couple of questions. There's one in the chat if you want to have a look at that,
Yeah.
Sandy, and then there's a couple in the Q&A.
Yeah. So Rasika asked if there's how do you tell the difference between slap cheek and roseola infantum? Probably it's a really good question. I would say that slap cheek is fairly typical in the bright red cheeks and perioral pallor, but roseola tends to be more on the body. You kind of, in a way, you kind of can't be sure. And I would I'd say somewhat provocatively, do you care? And the anxiety there is around pregnant women. And we had a child referred in with query slap cheek, can you do testing on it? And we said, well, I think the mother needs to check her serology with her obstetrician. That's just the easiest way to do it rather than wait for the serology to come back on the child. So if the child's well, then it kind of doesn't matter for that particular patient. And managing the, if you like, anxiety around any pregnant people in that environment would be around obstetric management. I hope that answers your question, Rasika. Yeah, but sometimes you can't tell.
Yeah, that was a brilliant question. Thanks, Rasika. We've got a couple of other questions here. This person asks, I hope this is not too much off topic, but when should we be concerned about GPA strep infections? Example, on a swab result, do they all need treatment? Are there any particular sepsis signs?
Great. Yep, good one. It's coming up. Yeah,
Brilliant.
that's everybody's anxiety right now, or that's a massive anxiety around, and I'm going to cover that a lot
Brilliant.
in a few
Okay.
slides. Yeah.
All
Yeah.
right. Next question. Whether topical hydrocortisone 1% is an ideal to be applied on kids. Majority of parents receive it from chemist before presenting to PPCC.
Yeah, yeah. Good one. So topical hydrocortisone is safe and fine for children. I suppose what you might be dealing with is an eczematous rash that's not getting better on 1% hydrocortisone. That's probably common presentation. And firstly, make sure it's a diagnosis that is going to respond to it. So if you've got, for instance, urticaria, it's not getting better on hydrocortisone, well, it doesn't anyway. But if you've got eczema that's not getting better on 1% hydrocortisone, then you can step up to stronger steroids below the neck, possibly stronger steroids for a few days above the neck. But often there's the skin cooling, the wet dressings, the avoiding the prickle, the cooling the child down, lots of the moisturizers, bringing in that package of care is going to yield better fruit for you. I hope that answers the question. And if you want to rejoin with that, if that wasn't the right answer. Question about acute management of bleeding hemangioma. Yeah, hard, difficult, really hard. Pressure. There's a lot of dressings that you use for, say, adults with venous ulcers that are quite good. They're, suffice to say, they're really hard. if they are bleeding, you put some pressure on. You put colors. I can't remember the name of it, but it's a kind of gooey sort of dressing. And if that doesn't stop it, you refer it in, and we ask our plastics to look after it. Our plastic surgeons. Sometimes they admit. Sometimes we bring them in under hospital in the home. Sometimes we apply some other stuff like TXA and things like that, I think. But they can be really quite bothersome because they're abnormal vessels. Good question. Yeah.
Brilliant. Thanks, Sandy.
Okay. Just doing my time check. And one of my kids wants to borrow my bike tonight, which is good. Yeah. Yes. So next one, well baby 3 weeks old, and we've covered this. We've covered this already. It's a really well baby. It's quite kind of pustular, deep, a little bit cystic, and this is neonatal acne. So I must say, when I look at that photo, I'm not going, well, isn't that erythema toxicum? But it's so I think it is on a spectrum. It's more inflammatory, got more pustules, and I refer them if it's persisting after 6 weeks. It usually doesn't. Here's a red patch noted at birth. What are we dealing with? Yeah, so we've got port wine stain, hemangioma, stalk mark. So this is a port wine stain. So this is a kind of quite a dense, usually unilateral, uniform, flat red mark, and they're usually unilateral. In certain areas, usually in the head, you can have complications with the eyes. If they cross the midline, then you want to go for neuroimaging. And this, if you're seeing a port wine stain developing in a child, you would treat this with laser, and you'd call the dermatologist for that one. Questions on that?
No, none. Thanks, Sandy.
No. Good. So I think, Don, I think you said cellulitis, and yeah, in the right context, if that was acute and painful, yeah, you would be, and a little bit swollen, you'd be dealing with cellulitis. And the stalk mark are in typical places, back of the neck or between the eyebrows. So this child is unwell, red, and hot. So tachycardic, grumpy, doesn't want to move around, a couple of vomits, and he's red all over. Are we happy? What do we think's going on?
One participant has said TEN.
Yep, agreed. Toxic epidermal necrolysis or necrolysis. Someone else saying staph, which is, of course, the cause, which is one of the causes of TEN. Sorry, it's not. It's related, but not the same cause. But what we're dealing with is a hot, unwell, red child. And what we're dealing with is the exotoxic staph and strep diseases, TEN and Stevens-Johnson. Yep, that comes into it. But these children are unwell. And I displayed this one because it can be hard to pick in children of African or subcontinental heritage. But you usually have the control in the parent in the room. So sometimes you need to sort of compare to someone else who's in the same family to get a feeling that they're erythrodermic. But this is badness when you're seeing, and this is where group A strep comes in, when you're seeing a child who's red all over, or who has a rash and a fever and unwellness, they could have one of those problems like group A strep, staphylococcal scalded skin syndrome, and you need to refer them in, and it can get very, very nasty. This is staphylococcal scalded skin syndrome, where the skin comes off in sheets. These children are unwell. So harking back to the group A strep, because we're all on the lookout for group A strep because it's on the upswing. Relatively easy when you have a feverish, unwell child with a scarlatiniform rash or erythrodermic rash. They need to come in immediately, possibly even by ambulance, depending on how sick they are. We take them very seriously. We jump on them in terms of early access, antibiotics, admission to hospital, and some of them get very, very sick. The even more difficult child is the child who is unwell, who has ill-defined pain, who's tachycardic, who's vomiting. And granted, many of those children have an early viral illness, the flu, etc., but some of them have group A strep. And if you're sitting on a child who's unwell like that, where you're worried about it, they need to be watched. They need to be observed so that they declare themselves or treated immediately, one of those two. And I'm not sure how how set up your PPCCs are to do that. So you would be referring them in. And as I said earlier, most of those children we turn around after a period of observation, but some of them we go aggressively in terms of their treatment. So, second slide of the talk: an unwell child, if they're unwell, that trumps any rash, red or not. You need to take that seriously and refer them in. Questions about group A strep. So yeah, this is a tricky one. There's a positive swab in the throat comes back after a couple of days. So if they're still sick and feverish, then you treat them with penicillin. There's a poor relationship between strep pharyngitis and invasive group A strep. So it probably gets in through the throat, but it's not the roaring sore throat. This just tends to be a lightning strike out of the blue, the invasive group A strep. And those children are non-specifically unwell, often with ill-defined limb or truncal pain. They're sicker than your average virus. They have a bad gestalt to them, and they're hard to pick. And that's why we see tragic cases all around Australia, in fact, the world, because they're very hard to pick. And as I said, if you're worried, you need to refer them in. It is over-referral. We over-investigate. We over-observe. That's the numbers game we're playing. When it comes to bad sore throat, is it strep, is it not? Well, you can swab the throat. Most children under 5 don't have group A strep. The group A strep of the throat doesn't usually transform to invasive group A strep disease, so you're not going to avoid that. I think you've got the ethnic, so the genetic and ethnic groups that are prone to rheumatic fever, who need a different pathway. So Aboriginal Islander, they need totally different thought processes and paradigms. But for your urban-based patient not in those ethnic groups, you don't necessarily need to swab. If they're over 5, maybe you treat them, maybe you don't. You're not going to prevent complications in any real quantitative fashion. I'm going to pause there because this is a big topic for everybody. Irona, respect you trying to discern EBV versus strep throat and found it was not very good at predicting. Any tips? Stop caring. Sorry, that was a joke. Test for both, I suppose. Yeah. EBV tends to be a bit more chronic. They tend to have a spleen. There's a gross overlap. You can, if you've got a sick child, as in if they're really unwell and they've got a horrible throat, give them some penicillin, give them some dexamethasone. That helps with both EBV and strep throat. Do your testing, your serology and your monospot and your throat swab. and see him in 48 hours. Antibiotics for teenagers. You've got the Centaur criteria that you can apply. I think I'd just do that. It's hard. I've got to say, antibiotics, you can rest assured, or you can rest in the knowledge that even if you give antibiotics for proven strep throat, they get better about 8 hours earlier. That's all you do with an antibiotic script. Okay, I'm going to move through on the home straight now. I think we're making pretty good time, 7:14. This is a patient who has eczema and now has funny spots. They're well in themselves. And the spots are really prominent on the thighs. There's a few blisters, and on the thighs, on the buttocks, on the forearms. Had a fever a few days ago. Any idea what this might be? Okay, I'm going to speed up here. This is eczema coxsackium. Yep, secondary infection, infected eczema, eczema herpeticum, all good thoughts. If the child is well with a typical distribution of hand, foot, and mouth, it's not painful, more itchy. It's eczema coxsackium. And we're seeing a lot of it because hand, foot, and mouth is everywhere in Melbourne. So for me, the dead giveaway is the child is well, they're itchy and not painful, maybe a mild fever, and you've got that typical distribution on the arms, on the buttocks, on the thighs, or sometimes just peripheral. On the other hand, you've got eczema that is flared like nobody's business, has little vesicles, has punched out areas, and is really sore, and the child is febrile. That is eczema herpeticum. It's a flare like they've never flared before. You stop the steroids, you give acyclovir, which can be hard to get because it's not on the PBS, and it's 5 times a day. If there is yellow crusty stuff, and there often is, then go down the staph, treat for staph as well. Lots of moisturisers and cold compresses. If they're sick, they often come in on IV antibiotics. Okay, a couple other ones. Yeah,
question here, Sandy. Can antibiotics be given for infected eczema or impetigo?
Yeah, they should. In fact, yes. So if you've got a lot of yellow, crusty, weeping eczema, you're going to have staph there. So you want to use, for a very small area, you could use topical, but otherwise you'd use, say, cefalexin. And also bleach baths. There's a recipe on our website, and that reduces the staph burden throughout the skin, because eczema skin is open, it's vulnerable to staph infection, and staph makes it more itchy, which makes it more open, which gives it more staph. So you're in a vicious cycle there. So yes, you got weepy yellow eczema, it's going to have staph in there for sure.
Brilliant. Thank you for that. And I think we've already got some diagnoses for the current slides.
Kawasaki, yep. So I've capitalized unwell because the kids with KD are not happy and bouncy. They are unhappy and miserable. They are uniformly grumpy as, really, really grumpy. And they have a collection of signs that you all know and on the next slide. So they have a high fever and they're really quite unwell and miserable. 5 days is the diagnostic criteria, but if you're heading towards 3 days and they're getting some signs, then I think that's a nice time to refer them in. They have a combination of mucous membrane changes, rash, including, which is polymorphic, but can also involve peripheral changes, the eyes with the epi, or the scleritis with limbal sparing, a single enlarged node. So if you're starting to see those accumulate, we're delighted to see those kids and consider, or we being paediatricians rather than just RCH, would be very happy to see these kids and consider that diagnosis, because the complications of cardiac problems are real, are uncommon, but are real. So we do want to see those kids. But you've got a well child with 2-3 days of fever and a bit of a rash and a bit of conjunctivitis, probably not. You just keep an eye on that one.
Sandy, we've got a couple of questions here.
Yeah.
I had a 2-year-old with eczema and I swabbed the eczema and it had PCR positive HSV, but child well. Do we treat with topical?
No, I'd probably treat with systemic acyclovir. Yeah. It's hard. I mean, if the eczema is getting better, because PCR takes 72 hours to come back, if the child's getting better, then maybe that's resolving eczema herpeticum, which I'm sure it will resolve if you leave it alone. But if the rash is still going and they're still a bit sick, then I would treat with systemic. I don't think topical, Stephen, will be enough unless it's just a tiny area, and in my experience, eczema herpeticum is quite large, quite extensive.
Brilliant, thank you.
Good-o. 2 persistent itchy round red spots. The one on the left is round, it's red, it's a little crusty. The one on the right isn't crusty, it's round, it's red, and maybe the central clearing. What do we think? I think my next slide says discoid eczema versus ringworm. Here we go. Which one's ringworm? Which one's discoid eczema? And I'll put my cursor on the right-hand one. What do we think the right-hand one is? Because one's eczema and one's ringworm.
We're getting some guesses or diagnoses on the Q&A. Fungal, the right one is fungal.
Yep. I think ringworm, you're right. So we've got ringworm on the right and discoid eczema on the left. And again, it can be hard. I do struggle with this from time to time. I often take a happy snap and send it to my friendly dermatologist. But ringworm, they're both itchy, but central clearing is more common with ringworm. It's slowly growing and has raised, heaped edges. Whereas the discoid eczema for me is crusty. It tends to be a bit more static. It's got much more inflammation in the middle. It's in a kid who's had eczema, and there's possibly a bunch of different lesions, all of roughly the same age, whereas these ones come up in different ages. That's how to tell the difference according to the textbooks. It's not always that simple.
Sandy, just cycling back to Kawasaki, can you extrapolate a little bit on what defines very unwell when it's Kawasaki's?
Yeah. So wellness in a child's hard to break down. It's like the castle. It's just the vibe, Your Honour, but that's really hard to impart. I think if you divide it into airway breathing as one bit, circulation and neurology, disability neurology. So if the child has fast breathing difficulty, fast breathing or laboured respirations, obviously colour change, cyanosis, that's in the AB. In the C, if they have tachycardia, poor peripheral refill, poor capillary refill, hypotension, which is late. And on the neurological, which is, I think, probably the biggest giveaway, is if they're not behaving or reacting the way that you would expect them to react. So an 18-monther is going to fight me off and cry and struggle, as an example. But if they're not doing that, then that's abnormal. So if the child is not reacting in the way that reacting with their parent, environment, and you in the way that you'd expect them in that healthcare moment, the more problems you've got with each of those 3 facets, the more unwell the child is. Does that make sense? And I suppose as GPs, you tap into your experience in that you've seen large number of mildly unwell children who don't bother you, but then there's a child who is carried in or don't often walk in, where it's just like, oh, no, this child's, doggo, they're not reacting very well. They're really shut down. They're cold. They're anxious. They've got deep sighing respirations. There's something abnormal about that child's appearance and reactivity in your surgery that makes you think something wrong, something bad's going on. And it might be DKA. You never know. It could be something quite much harder to diagnose. But if they're not behaving and acting the way they should, then they're unwell. Sometimes by the time they get to us, they're well. Sometimes, you pop them back out while you're making the phone call, they perk up. That's the nature of the business. And specifically with KD, Kawasaki disease, they don't tend to improve and get back to running around and having fun and eating bananas and doing all the things they normally do in between the fevers. I hope that helps.
Thank you so much for that. And another question just about the eczema versus ringworm.
Yep.
Is the best way to diagnose ringworm from the lab scrapings or PCR? If the child is crying and moving, blade for scraping makes me nervous.
Yeah. I mean, skin scrapings, you scrape the back of a sharp blade across an uncooperative 18-monthers skin, you put it in an envelope and you send it to the lab, and then 6 weeks later you get a result. So quite unsatisfying in many different ways. What I tend to do is have a good stab at it and treat what I think is going on and look at clinical response. And, the question is, if you put steroids on ringworm, does it take off like a rocket? And maybe it's uncommon. So I tend to just have my best guess and treat because of that unsatisfying way that you have to chase it down. So it's not PCR. On the other hand, sometimes I have a belt and brace approach. It's like I really can't tell. I'm going to treat with both topical Bupros and topical steroids.
Brilliant. Thank you.
Like that sometimes.
Sandy.
Okay, we saw a lot of this in June 2020. Itchy, painful toes in a teenager. What do we think?
We've also got on the Q&A
vasculitis
for picture of toes.
It is vasculitis. Everyone's saying chilblains. That's great. I think you probably agree with me. We saw buckets of chilblains during COVID. This is chilblains, which is a type of chronic cold injury vasculitis. So it's both. But for me, do you investigate this or do you just call it chilblains? And for me, I don't investigate. I agree with you, Amanda. I don't investigate if you see this about a week after the cold snap or during COVID times. We saw it when all the teenagers were at home without shoes on in June. So we saw a lot of chilblains. So I don't investigate if you've got a cold setup. I investigate if there are other clinical features suggesting connective tissue disease.
We've also had the brilliant suggestion, Sandy, that they buy some socks. And I would suggest that Australians are pretty hopeless when it comes to cold weather and dressing appropriately. Yeah, agreed. And boots for sure. And don't wear runners at school. Or if you're wearing runners, wear woolen socks with your runners. In August, cotton socks and Nikes in the schoolyard, very cold, especially if you've just hit 6 foot as a 14-year-old teenager. Pick looks like Pomflix. Yeah, it could be Pomflix, I guess. Off topic, is group A strep more common in the setting of a recent viral illness? Yes, it is. But because everyone's had a recent viral illness,
it doesn't help, unfortunately. Warts now getting infected. So child has had warts and they present to you because they're all red. Molluscum. I'll come back to that question, Stephen. Okay, so this is molluscum. So on that top right picture, you see the typical pedunculated lesion, sorry, umbilicated lesion. And now you're seeing some redness and some eczematous changes. This one was referred in with infection, and this one too. And in fact, I don't think these are infected. What happens is the body, after a year, 6 months, a year, 18 months, recognises it as foreign and starts rejecting them. Usually one or two go off one or two go off initially. It's a bit like popcorn in the oven, in the microwave. One or two go off and then they all go off at once, and triggers immune reaction in the skin with eczema, an inflammatory reaction with maybe 5 to 10 millimeter of inflammation around, and then it rejects that little cheesy core and it almost looks like a pustule, but it's not infected. If it's really painful and larger than, say, 5 or 10 millimeters, you might go down the infection path. And certainly with the eczematous change, which are itchy and uncomfortable, you can use steroids and that won't dampen down your rejection reaction. They're on the way out. And that's molluscum. And that's what we've got. Now, I'm aware that I've hit 7:30. So I think I've got one slide to go. This is probably, I'll go through this really fast. Large red areas, cellulitis. How do you tell the difference between a large local reaction and cellulitis? So you see parents come in with a giant red patch on the arm. And is it cellulitis or is it not? And for me, cellulitis is tender. Child is unhappy. They could be febrile. There's limitation of use of that part of the body. Whereas a bite is itchy, it's non-tender, the child is well, and they're moving it. And hopefully you can tell the difference, but sometimes I reach for both antihistamines and antibiotics at the same time. And I'm going to hit the summary now. Most rashes are benign. So if your child is well, the rash is probably benign. There are only a few rashes that are harbingers of serious illness. The purple rashes probably being the most prominent. If you have a sick child, and we defined that, and that was a great question. If we had a sick child with a rash, they're sick. They need to be seen. Blisters and peeling can be problematic. Pigment and brownness also have some traps in them, and birthmarks near the openings. Here are a number of resources that I reach for quite a lot. And we'll throw it back to you, Della.
Brilliant. Sandy, I've just got a couple of questions still from the Q&A.
Yep.
Is there any role for RAST with itchy rash?
No, I don't think so. I don't think our allergists don't really use RAST tests very much. They tend to do a detailed history and skin prick testing or patch testing. So they tend not to rely on RASTs.
Brilliant.
Yeah.
Thank you. And lastly, cold sores, topical
early
cream indicated?
Yeah, early. If they get onto it early, it's certainly not harmful. I'm not sure about the evidence of it preventing it getting worse, but I don't get cold sores, but most people get cold sores, really don't like them. So yeah, go for it.
Yep. Another question, how long should we ask the parents to wait for the benign rashes to vanish if children are not unwell?
Yeah, I wonder if we're talking about creche or school exclusion. So I think probably if a child's well for 48 hours, if it's a benign viral rash, so not, measles or what have you, then if a child's well for 48 hours, they should be, probably classified as clear for creche or school or daycare. I think that was what the question was about.
Yeah, brilliant.
Or it might be, if the child's well, when do we get worried if a rash hasn't gone away? And that would be, I don't know, depending on the type of rash, a long time. 2 weeks, a month.
There's another question in the chat. In the early stages, are there clues that can differentiate between erysipelas
Erysipelas and toxic necrotizing fasciitis? Yeah, I think toxic necrotizing neck fascias, you've got dead tissue advancing very quickly through a limb. So you're going to have someone who's got ongoing sepsis. So they're going to be, unwell with tachycardia, etc. They're going to have an absolute truckload of pain as well. So the pain out of proportion to the local signs are probably one of the biggest giveaways for neck fash. Having said that, erysipelas is pretty painful too. And short story is, if you think you're sitting on neck fash, even if you think you might be, but you're not sure, that child needs to be seen by an emergency department, because if you miss that, there's bad consequences. So yeah, refer them in if you've got a concern about that.
Sandy, we've got another question. Recurrent impetigo, bleach baths, would
Yes.
you or advise
Yes.
microshield wash?
Both. I think bleach baths are really good because they get everywhere. I think the microshield wash, I particularly do the fingernails, etc. Couple of things, particularly in paediatrics, I'd trim and file the fingernails. I'd ask about nose picking and scratching, and I would control any itch as best you can. Can't always control it. Because the impetigo, the staph lives in noses, armpits, etc. So you want to eradicate that as best you can. Staph needs a chance to get in, which is scratching and poor skin health. So there's a kind of raft of stuff that you do for recurrent impetigo.
Brilliant. Thank you so much. Sandy, thank you so much for a stomach churning but extremely expert presentation on rashes in children. One last thing. Oh, no. Bactroban versus fusidic acid.
No, I use Bactroban for no other reason than that's what my consultant told me back when I was a trainee. So yeah, I use topical mupirocin. I'm not aware of any benefit in either of those two.
Yeah. Brilliant. And I also wanted to just thank you for pointing out about diagnosing kids with more melatonin in their skin with a darker skin shade. And I thought that sounded like very sound advice to actually look at their parents' skin color as a comparison. And also I noticed that in your resources, you also did have the resource from the UK about
yes,
black and brown skin.
blackandbrownskin.co.uk. Yeah, I think that's really useful because we're, most of us who are lighter skin, we don't really have a sixth sense about these subtle changes, and we need to get better. Agreed.
Yeah, absolutely. Yeah. Another question we have here is, how do you pronounce that? Mupirocin be given to any age group in babies?
Yeah, I must say I don't Yeah, probably is the short answer. It's in the under 28 days, you probably don't have much of a need for it. But I'm just thinking back to most babies do get staph and do get bullous impetigo and impetigo in general, and we tend to treat them with oral cefalexin because it tends to be a bit more extensive. So I can't remember. I probably wouldn't be shy of it because it's topical, but both are off-label. Yeah. So I'd probably be more in favour of cefalexin than mupirocin, but I don't know about mupirocin.
Brilliant.
Good. I might call it quits at that
Yep.
stage because
Thank
thank you
you.
for listening to me, and thank you for coming along and sparing your time off your after hours time. I hope it's been helpful, and please be as brutal as frank as you can about the feedback, because I'm only imagining what you need to know. I really want to hear what you actually need to know.
Thank you so much. And if everybody could just get their phones out and take a picture of the QR code and provide that feedback. That feedback gives us really great data for making relevant presentations to you. So please do that. It'll only take a couple of minutes max. And we're already getting heaps of amazing feedback in the chat, which is fantastic. Thank you so much. But we really need it in the QR code. So thank you so much, everybody. Thank you, Sandy, for your absolutely excellent presentation. And everybody have a great evening.
All right, we'll see you all later.
Thank you.
Bye
See you
now.
later.